right, so urinary system disorders. Okay. Let's see. I don't have my little thing here today. All right, so just a little bit of review of normal functioning of the urinary tract. There are a number of hormones that play an important role in controlling essentially how much water and or salt we excrete. You know, we don't drink the same amount every day, but we have the same, generally we have about the same requirements. So the kidney has to be able to modulate how much water is removed from the body. So the antidiuretic hormone is secreted by the posterior pituitary, and it triggers the reabsorption of just water. So ADH is important because these other mechanisms really work on salt, not on water, but ADH actually works on the water, reduces the amount of water in the urine or increases the amount of water in the urine, depending on what the body needs. Because aldosterone, it can increase or decrease the amount of urine that's produced. When aldosterone goes up, the amount of urine produced goes down, but it does that by using sodium. So basically, when aldosterone is present, more sodium is pumped out of the urine in exchange for potassium, and essentially more water is reabsorbed, so less urine is made. And then the atrial natriuretic peptide is the only hormone that works in the other direction, that actually works to reduce plasma volume by increasing the amount of water that's in the urine. So it reduces both sodium and fluid reabsorption. And that works, it's created by the heart in response to the atria being too full prior to contraction. So essentially when your plasma volume is too high, the heart secretes this atrial natriuretic peptide, ANP it's usually called, and that triggers the kidney to get rid of excess sodium and water. All right. So all of the urinary system disorders sort of share some common diagnostics, which includes looking at the urine itself. Any good kidney specialist will tell you that, urine is where you're likely to find the answer to a problem with the kidney, because the urine gives us a sort of snapshot of how well the kidney is working. So normally urine is sort of straw-colored, and it has a mild odor that's from the ammonia and the urea that's present there. The specific gravity is usually 1.01 to 1.05. So still quite a bit, has a lot more contained in it than, typical water that you'd find out of the tap, so to speak. But the body can dramatically increase that by recovering water, and that makes the specific gravity go up. So some abnormalities, some not normal things you might see in the urine. Cloudiness. Urine is supposed to be clear. In other words, it has a color to it, but you should be able to see through it. If it's cloudy, that may be indicative of lots of protein in the urine, which happens in nephrosis or in glomerulonephritis, which we're going to talk about later. It could be blood, bacteria, or pus, which is white blood cells. So cloudy urine is usually indicative of some problem. Now, urine can be cloudy in the normal person if they're very dehydrated. In other words, if there's a lot dissolved in that small amount of urine that they're making, that can contribute to cloudiness too. Dark color, hematuria sometimes is first seen as a change in the color of the urine. So it starts to get sort of tea-colored. If it's actually grossly red, that's significant hematuria. That's sort of a medical emergency. You'd want that person to be seen right away. If the patient's bilirubin is high, that too will make it sort of a dark orange color or even a greenish tinge to it. And then, again, in dehydration, the urine is so concentrated that its normal color is just amplified. So that can be a reason for the dark color too. Unusual or unpleasant odors can either be signs of infection or can be the result of certain things in the diet or medications. Some medications, some particularly herbs and spices, actually just get excreted into the urine relatively unchanged. Garlic is infamous for this. It not only gets into the urine, but it gets into the sweat too, so you actually smell the meal that somebody had last night. So that's dietary components. You should never have blood in the urine. It's always abnormal to have blood in the urine, particularly if it's a clean catch urine, in other words, where blood couldn't have gotten in from somewhere else. In just a normal urinalysis in women, it's very common to find some blood in the urine because of menstruation. But if it's a clean catch, you shouldn't have that. So if you have just small amounts of blood, that could be a sign of infection, any kind of inflammation of the bladder. The bladder is kind of quick to bleed, but it doesn't bleed very much. So anything unusual happening in the bladder can trigger a small amount of hematuria. Tumors in the urinary tract, lots of blood in the urine, so we're talking gross blood now. In other words, you can tell when you look at it that there's blood in the urine. That's going to be due to something wrong at the glomerular membrane. The glomerular membrane sits between what will become urine and blood. So if that thin membrane breaks down and blood is allowed to cross into that peritubular space where the beginnings of urine, then you're going to see that blood coming out in the urine because there's no mechanism for getting that blood back out. So, and we'll see that here in a little bit when we talk about glomerulonephritis. Or a hemorrhage. So a hemorrhage in the ureter, like from a kidney stone, a hemorrhage in the bladder. Any of those, are going to cause a significant amount of hematuria. Protein. There's always a little protein in urine, but there shouldn't be very much. The proteins, generally speaking, that are found in plasma are too big to get through that glomerular membrane. That membrane is supposed to leave all the good stuff behind and just let through what we want to get rid of. So a small amount of protein can be normal, but anything past that, and again, it's a sign that the glomerular membrane is sick or damaged, that protein is being allowed into that filtrate. And then in the case of infection, you'll find bacteria in the urine. Urine is a very good medium for the growth of bacteria. It has lots of nitrogen, and some bacteria just love nitrogen compounds. So we can culture urine and find bacteria there if there's an infection. All right. So this is just we look at urine under the microscope sometimes. What we're looking for is either blood, casts, which I'll talk about in a minute, or bacteria. So like in this picture, you can see all these red blood cells. They don't belong in urine, so you shouldn't find those. And then you have a bunch of these little rod-shaped things. Those are your bacteria. So, in a massive urinary tract infection, you might even see more than one kind of organism. So you might see gram-negatives, gram-positives, or both. So other things we might see under the, another thing we might see under the microscope are casts. Now, you'll have to remember that, the nephron is sort of shaped like this, right? And then it has this tubule, right, that comes down. Well, in certain diseases, things sort of pack into this space right here. Cells can pack in like that, red blood cells, for example. Material that doesn't belong in the urine, the same kind of stuff that makes urinary stones. But a urinary cast is, you'll see a structure in the urine that sort of looks like this. And it means that something got packed in that nephron and then and eventually got passed out, and you'll see it looks a little bit like this. So this is a red blood cell cast. You can sort of see the shape of part of the nephron. They're all clumped together in sort of a shaped clot. So that's a sign that, again, there's something wrong at the glomerular membrane. We look at specific gravity. This basically tells us how concentrated the urine is. It's normal for there to be a range. So like first thing in the morning, you haven't had anything to drink in, 6 to 8 hours. So very often that first morning urine is quite concentrated. So its specific gravity is going to be high. If you're drinking plenty of fluid throughout the day, though, it's best for your kidneys to have a lower specific gravity. It's one of the reasons why we recommend that, people drink that 32 ounces of water every day, is to try to keep the urine dilute, because dilute urine is easier for the kidney to make, and it's also much less likely to cause things like kidney stones, precipitation of substances out of the urine into a solid form. And then glucose and ketones. In the normal person, you should never ever see glucose in the urine. So any amount of glucose in the urine deserves a workup for diabetes, because the range, you don't start seeing glucose in the urine until the plasma glucose is like 300. So that's 3 times normal. So any positive glucose test in the urine is significant clinically. And then ketones are molecules that the liver releases in response to starvation. So if the cells are not getting enough glucose, the liver starts creating ketones, which provide for the energy needs of the cells of the body. However, these ketones also appear in the urine. So it's either a sign of dehydration, starvation, or the most likely cause is a diabetes situation. Because in diabetes, even though the blood sugar is very, very high, none of that sugar is getting into the cells. That's what creates the problem in the first place. So you see sort of a person who's metabolically starving, even though they have tons of glucose around that they could use, but without sufficient insulin, that glucose can't get into the cells where they're used. So these two are very commonly associated with diabetes, ketones and glucosuria, or glucose in the urine. All right. In addition to looking at the urine, we can look at blood tests to tell us about kidney function. Urea and creatinine are typically, they're part of the Chem 7, so it's one of the most common metabolic tests that we get. If the urea is high or the creatinine is high, that suggests that there's a decrease in glomerular filtration rate. In other words, there's a decrease in the speed at which the kidney is making urine. So both of these are significant if they're elevated. Now, the most common cause for elevations in those two things is simply dehydration. In other words, the patient doesn't have enough water to have gotten rid of those substances yet. So that's the most common reason. But in the normally hydrated patient, an elevated urea or creatinine suggests kidney pathology. It suggests that there's something going on in all those nephrons. A metabolic acidosis also indicates a decrease in glomerular filtration rate. This is because the kidney works together with the lungs to get rid of acid that's produced in the body. Most of the acid we produce, we end up blowing off as CO2, but the kidney is responsible for the other half of that equation, so to speak. So if we have a patient whose pH is low, but their CO2 is normal, it suggests that the kidney is not getting rid of the acid, or that there's some other source of acid coming into this patient. So it might be a medication overdose or something like that. And then anemia. You wouldn't necessarily think that the amount of red blood cells in the plasma would have anything to do with the kidney, except it's the kidney that controls how many red blood cells get made, and that's through the hormone called erythropoietin. So anytime you have a kidney disease, very likely you're going to have an anemia too, because when the kidney gets sick, it doesn't produce EPO, and if there's no EPO, the bone marrow doesn't produce enough red blood cells. So anemia very much goes together with kidney disease because of that erythropoietin that you probably learned about in A&P. All right. Electrolytes, the kidney is responsible for managing sodium levels, potassium levels, calcium, magnesium, all of those minerals that we talked about in our first unit together. The kidney plays a role in managing all those. So when the kidney is sick, a lot of times electrolytes get out of whack too. And then if we're looking for specific kidney diseases like glomerulonephritis, then we're going to look for things that are specific to it. So antibody levels, we'll talk more about that in a minute. And then the kidney, in addition to controlling how many red blood cells are made, the kidney is also the blood pressure manager of the body. So again, when the kidney is sick, often hypertension goes along with that, Now, this is secondary hypertension because it's, primary hypertension, there's no other cause. So in kidney disease, we get a secondary hypertension as renin levels go up. Renin is secreted by the kidney in response to either inadequate blood flow or inadequate glomerular filtration rate. So essentially, when the kidney gets sick, it responds by increasing blood pressure. And a lot of times, that's not an appropriate response. The kidney ends up making its own problem worse, but we can get a renin level to help us make that determination. And then some other tests, culture and sensitivity. Just like any other bodily fluid, we can put it in a growth medium and we can see if there's any bacteria there. Urine should be sterile. It's one of the sterile fluids of the body. So just like blood should have 0 bacteria growth, urine also should have 0 bacteria growth. So if anything grows out of the urine, it's either contamination, it wasn't a good clean catch, or it's a urinary tract infection and deserves treatment. So remember that. Even though we all think of urine as dirty, it's actually sterile. I mean, you wouldn't want to be anywhere near it, but it's not infected. So urine should be sterile. And then, while we can't directly look at the kidney's function radiologically with x-rays, we can look at the anatomy, and with some fancy tricks, we can see how well the kidney is doing its job. For example, we can give somebody an IV medication, and it will show up in the kidneys as the kidneys excrete that medication, and we can get a picture of the kidney working that way. All right. We're going to skip that stuff. When the kidneys fail, you have to have working kidneys, at least one. And the reason for that is the kidneys are responsible for getting rid of our metabolic waste products. We put nutrients in, carbohydrates, lipids, and proteins. Most of what that becomes is CO2. Most of the carbon bonds get broken and we exhale CO2. But anything else, in other words, anything that doesn't get broken down into just CO2 and water, has to be removed from the body somehow. And the primary thing that needs to be removed there is nitrogen containing, or the nitrogen atom. So like protein, has a nitrogen that's a part of it. We take in a lot of protein, and most of the protein gets broken down as fuel, but we still have to get rid of that nitrogen somehow. So the body makes urea to get rid of nitrogen, and it's the kidney that then gets rid of that urea to keep us in balance. So when the kidneys fail, we have to do that for the patient to keep them alive, and that process is called dialysis. So dialysis is basically kidney function by machine. Now, it turns out you don't have to have working kidneys all the time. You just need working kidneys, 2 or 3 times a week, so to speak, in order to get rid of the waste products that have built up. So when patients' kidneys no longer work, they start in on a dialysis routine. And essentially what dialysis is we take blood out of the patient with a pump. We pump it through a container that's filled with what's called dialysis fluid, and then we pump that blood back into the patient. Well, as the blood passes through this part right here, it's inside a membrane, so a semi-permeable membrane. Some stuff can get through, some stuff can't. So in some ways, it's just like the glomerulus. The red blood cells, the platelets, the white blood cells, the plasma proteins, they all stay inside the tube. But the smaller things like urea, like potassium, like sodium, like chloride, they come out and they can equilibrate with this solution that's around them. So by the time the blood goes back in, the urea has been removed, excess potassium has been removed, excess sodium. So it's essentially a simple kidney in a box, so to speak. So typically patients 2 or 3 times a week will go to a dialysis center for several hours and have this process done. And then in between those times, they're free to live their normal lives. So this is probably the most common kind of dialysis, called hemodialysis. The other kind of cool, I think, anyway, kind is called peritoneal dialysis. And here, instead of taking blood out of the patient and doing something with it, we take dialysis fluid and we put it inside the patient and make the same thing happen. So the peritoneal cavity, which is where your GI tract is a good potential space. In other words, normally there's not very much fluid in there, but we can put fluid in there and we can take fluid out. So in peritoneal dialysis, we put dialysis fluid in the peritoneum, and because there are lots of capillaries and blood vessels supplying the GI tract, essentially this very same thing happens. The small molecules end up equilibrating with the dialysis fluid, and then when we pull the dialysis fluid back out, along with it comes the patient's urea, comes the patient's excess potassium, sodium, and all that. So this is typically a bit safer to do because you're not actually taking liters of blood out of the patient and putting it back in, but it has some other potential complications. You know, like you can imagine infection as a complication here. Here we're taking fluid from the outside and putting it on the inside, but that's why this all has to be done sterilely. So peritoneal dialysis, this process repeats. Usually it's done at night while the patient is sleeping, and fluid goes in, it sits in there for a while, and then the fluid is pumped out, and then new fluid is pumped in, and so on. So that cycle repeats several times a night. And by the time they get up, their urea levels are normal, their potassium levels are normal. So it's kind of a neat trick. This is what's done most commonly in kids because it's hard to get vessels big enough in children to do hemodialysis, so they try to do peritoneal dialysis instead. All right. Okay, so that's sort of general stuff about the urinary system. Some diagnostics and then some treatment options. So let's get into some disorders. This one I know you've heard about in other places. So the UTI. Now UTIs can either can involve essentially any part of the urinary tract. So anything from a urethritis or an infection of the urethra to a cystitis, which is an infection of the bladder, all the way up into the kidneys, which is called a pyelonephritis, where the kidney itself has infection on the inside. UTIs are some of the most common infections, and they're some of the most common infections that require treatment. You know, the upper respiratory tract infection is the most common, but most colds you don't have to do anything with. The UTI is not like that. UTIs have a tendency to not go away on their own, but require treatment with antibiotics. And that's because urine is an excellent growth medium. There's always a little urine in the bladder. You know, we never completely empty our bladders, so it gives bacteria a nice warm place to live where nutrients are being provided by the kidney all the time in the form of urea. So the lower urinary tract infection, that's your cystitis and urethritis. The upper, which is by far the more serious, is pyelonephritis. One of the ways to tell the difference, usually a lower urinary tract infection doesn't cause fever. You know, it does cause inflammation of the bladder, so you get urgency and frequency. In other words, when you have to go, you really have to go, and you go all the time, or you go frequently. But there's usually no fever. If you're having fever and flank pain, that's your pyelonephritis. You know, this is a patient on their way to being septic because, you know, the infection has traveled from the urethra to the bladder, from the bladder up to the kidneys, and the next step is from kidneys then into blood. So pyelonephritis is a very serious illness. Many people are hospitalized for pyelonephritis, particularly if it doesn't get better in just a few days. Yeah.
Now, do the symptoms vary between the two? Like
between what?
Well, I know that the pyelonephritis is worse, but you know, like with the cystitis and the urethritis, you can like feel that like patients have like symptoms. You know what I mean? Or like the urgency. Is it the same?
Frequency and urgency. If it's an ascending infection, in other words, if it started here, went here, and ended up here, the symptoms add up. So you'll have frequency, urgency, and fever and fatigue.
But is it strep that people get, and then all of a sudden they have pyelonephritis, so they can get pyelonephritis from strep?
That would be from the other way. You're probably thinking of glomerulonephritis, which is post-streptococcal glomerulonephritis, which we're going to talk about in a minute. Okay. So yeah, pyelonephritis is the big bad one. The most common causative organism of all UTIs is E. coli. So E. coli is part of our gut flora, so it lives in our large intestine. And because of the proximity of anus to urethra, it is the most common causative organism. So just remember that one. UTIs are hugely more common in women than men. The theory of that is women's urethra is very much shorter, and it's short and straight, so it's much easier for bacteria to make entry into the bladder, and it's more proximal to the anus. So, classic UTI stuff. Also, we see UTIs in older men, and that's because of urinary stasis. Their prostates get big. That happens to many, many men. That big prostate means they can't empty their bladder. Anytime the bladder doesn't empty fully, your risk of infection goes way up because, again, it's a great place for bacteria to live, and the more urine you have in your bladder all the time, the higher the risk for that. Other places we see UTIs. Children should not have UTIs more than twice in childhood. So if you're seeing a pattern of UTIs, they're going to do a workup for congenital abnormalities. Something is probably not right with the whole urine delivery system. So either the ureters, the bladder, or the urethra probably have some problem. Incontinence, retention, contamination with fecal material like you might see in the patient who's unconscious, or the long-term neurologically devastated patient, you have an increased risk of UTI if there's fecal material that's in there. Think diaper. All right. So the various causes, most UTIs are ascending. In other words, they come in from the outside through the urethra into the bladder, and then if it's not treated then, it starts making its way up into the kidney, and then eventually it can go through the kidney and into the blood. But there's also the opposite path. In other words, an infection or a bacteria in the bloodstream can cause an infection in the kidneys. So somebody who's septic, they have bacteria in the blood, they can end up with a pyelonephritis because that bacteria seeds the kidney, that infection takes hold there, and you get the same symptoms. Obstruction because of retention, increased risk. VU reflux is one of those congenital abnormalities. This is where normally where the ureters enter the bladder. Here's the bladder, right? Normally this angle right here creates a kind of valve which prevents urine from flowing backwards because there's a valve here. In VU reflux, that valve isn't there or it doesn't work. So you end up with urine that goes backwards. Urine's supposed to go in only one direction, from the kidney to the bladder out to the world. So in VU reflux, we have it going the wrong way, and that increases your risk for pyelonephritis, which sort of makes sense. There's now a path for stuff here to go back upwards. So in children in particular, with frequent UTIs, they will sometimes go in and actually cinch up these valves to make them work better and stop that reflux. All right. So in cystitis, this is bladder infection. The bladder wall is inflamed, so that makes it irritable. The bladder doesn't want to be stretched because it hurts to be stretched when it's inflamed. So you have a small urinary capacity. That creates frequency, so the patient complains of having to go to the bathroom all the time. And then also that irritation causes urgency. So when the bladder does start to stretch and fill, because it's inflamed, it sends a nasty signal to the brain saying, I need to empty right now, because it wants to stay empty. So we see the classic symptoms of frequency and urgency. You might see pain in the pelvic area. You can get systemic signs, but this is a big fat may. A lot of UTIs only have localized signs. So pain with urination, frequency and urgency, but no fever, no leukocytosis, so your white count is normal. When you start seeing these systemic signs, you're worrying about pyelonephritis. You're worried that this infection has spread up and is getting into the blood. In a bad UTI, the urine can be cloudy, unusual odor, but this is a pretty rampant bladder infection by the time it gets to that point. Typically, the diagnosis of a UTI is by urinalysis. You know, we look at the urine, and there on the dipsticks that we use, there are a number of indicators looking for bacteria. So typically, that's how the diagnosis is made. And then treatment is with oral antibiotics. And there are a few antibiotics that actually concentrate in the urine. In other words, we give you the antibiotic by mouth. It goes all around your body, but it ends up being concentrated in the urine. So those are particularly effective antibiotics to use for urinary tract infections. Septra is an example of that, which is sulfomethoxazole. All right, so pyelonephritis. This is an infection involving one or both kidneys. Usually it's ascending, so it's gone from the ureter up into the kidney, and you get purulent exudate. So literally you get pus in the renal pelvis. Pyelonephritis has to be treated because kidney destruction can result if it's not. And in patients that have recurrent pyelonephritis or a chronic infection, in other words, difficult to treat, like you might see in somebody who's immune compromised, both of those things, every time your kidney is infected, part of it dies. And kidney doesn't grow back, just like heart and brain don't grow back, neither does kidney. So over time, chronic infection or recurrent infection results in loss of renal function. If it goes on long enough, you'll actually get into full-on renal failure. All right, so the typical signs for pyelo are cystitis plus that flank pain. People will point at their sides, and then systemic signs that includes a high temperature, and oftentimes the temperature will, it'll go up and down, but it gets significantly high. So treatment is with antibiotics. In all but the mildest pyelonephritis, we're going to treat with IV antibiotics, at least at first, because we want to make sure that we start that infection, that we kill those bacteria as quickly as possible to prevent renal scarring. Okay, so our first question, I have put up the student number question, so please answer that. 1, 2, 3, 4, 5, 6. So who's not on my thing? Who's not playing? You're not. You're not. Okay. Carolyn, did you ever get that to work?
Yeah. Should it be showing right now?
Nope. Not if you already answered the question. I'm waiting for 2 people here.
I can answer it.
Did you do your number?
Yeah.
There we go. That's everybody. Okay. Now we can move on. Email. Okay, so a person with acute pyelonephritis would most typically have which of those things?
While we're waiting for this, could you have pain, which would be sort of like an appendix area, but it could be kidney, or would you have it in the back as well, if it were?
Kidney and ureter pain is usually referred to the back.
Okay.
But I suppose if your ureter was infected, you could get pain in the front as it comes down, as they come down. All right. So the answer here is A, fever. These others are kidney symptoms. Oliguria just means a low urine output, which you're going to see that in end-stage renal failure. Edema, you're going to see that in nephrosis or nephritis, and that's because if you're losing a lot of protein in your urine, you start to swell up. The whole body does. And then hypertension is often associated with kidney disease, but pyelonephritis very much acts like an infection. The kidney is still working just fine, so, you don't see effects in kidney function. You see that the kidney is inflamed and irritated, so you have fever and pain. All right. The organism most commonly associated with acute pyelonephritis is which of those? Huh? Bless you. All right, I think everybody's answered. So the correct answer is B, E. coli. So E. coli is the most common causative organism for all UTIs. So this is your cystitis as well as your pyelonephritis. Don't get confused. There is an important kidney disease that's related to streptococcus. But streptococcus is not a common cause of UTIs. Now, it does cause UTIs in some people. But, you know, the classic board question, it's E. coli. Because streptococcus is associated with what's called post-streptococcal glomerulonephritis, which is actually an immune complex disorder, which we're going to talk about in a minute, like right now. All right, so that was infection. So you've got cystitis, pyelonephritis. Okay, the other big, or the second big group of renal disorders are the inflammatory disorders. So these have as their foundation that the glomerulus, or the nephron itself, is inflamed for some reason. So there are lots of forms of glomerulonephritis. So what does this mean? This is inflammation of the glomerulus and the nephron, both. So glomerulonephritis. The most common one that we see is from streptococcus. So we call it PSGN, post-streptococcal glomerulonephritis. And here's sort of how that works. You get a strep infection somewhere in the body. Usually it's the throat. The body's response to that infection is to create antibodies against strep. That's what the immune system is supposed to do. Well, there are some strains of strep whose antigens, or their parts, so to speak, resemble the basement membrane of the glomerulus. So basically, the body's attacking the strep, but by mistake, it ends up making antibodies that affect the kidney because there's some similarities there. So the antibodies end up forming antibody-antigen complexes. So this is an antibody with an antigen attached that's just freely floating. This complex gets caught in the glomerular membrane because, you know, it's a filter. So just like things get caught in your, sink filter, they get caught there. And then the presence of these antigen-antibody complexes triggers an inflammatory response in the glomeruli. So once that happens, the glomerular capillaries kind of start to break down. So hopefully you remember from A&P that we have our glomerular capsule, right? That's Bowman's capsule. And then coming into it, we have these capillaries that make this kind of tuft, inside. So we've got blood in these capillaries, and then out here we just call it filtrate. Now filtrate's going to go on through the nephron and become urine, right? It's going to have the good stuff reabsorbed, bad stuff added to it. But this glomerulonephritis is affecting these glomerular capillaries and making them leaky. So what we get is normally the red blood cells are supposed to go in here and come out here. They're not supposed to get out into the filtrate. In glomerulonephritis, we end up with red blood cells leak out, and we end up with protein that leaks out too. So what we see in glomerulonephritis is we see blood in the urine and we see protein in the urine. And that's an important distinction because in another disorder we're going to talk about in a minute called nephrosis, we only see protein but we don't see blood. So glomerulonephritis allows blood and protein into that first part of the nephron. And then because there's no mechanism for getting it back out, because it's not supposed to be there, it ends up appearing in the urine. So we see blood hematuria and we see proteinuria with glomerulonephritis. Now, because of this inflammatory response, we not only get the breakdown of the glomerular membrane, but we also start to see effects on kidney function. So we have a decrease in glomerular filtration rate. That means the kidneys are producing urine less fast. Less fast means that more fluid is retained, more waste products are retained. So a bad glomerulonephritis can result in an acute renal failure where the kidneys are no longer functioning because of this big inflammatory response. So based on that pathophysiology, that explains the symptoms that we see. So we see urine, dark and cloudy. Dark, that's the blood. Cloudy, that's the protein. We see edema. As we lose protein into the urine, we have less protein in our blood. Less protein in our blood means that there's less osmotic pull into the blood. Remember that blood colloid osmotic pressure? That starts to go away. So fluid tends to leak out into the tissues. So you get edema. Easiest to see in the face and in the eye. So, the eyelids. Left untreated, you'll get generalized edema. Now, generalized edema can be hard to spot, but one of the easiest ways is to follow patients' weights. So if their weight is going up significantly day after day, that means that they're getting more and more fluid in their extracellular space, and that fluid is hard to get out once it's there. We'll see an elevation in blood pressure. Again, one of the kidney's responses to irritation is to secrete renin, and that renin causes an elevation in blood pressure and a reduction in urine output. Flank or back pain again, this we see anytime the kidneys are upset about something, and then a decrease in urine output and the generalized signs of inflammation. So fatigue, lethargy, myalgia, maybe even some low-grade fever. So we look for glomerulonephritis by looking at the blood and the urine. So we see an elevation in urea and creatinine, that's signs of a low GFR, which we just talked about. For the streptococcal version of this, we can look specifically for those problematic antibodies. So we look for anti-DNAase, streptococcals, anti-streptolysin. There's a panel on this. We call that the post-streptococcal glomerulonephritis panel. So we're going to look for those antibodies that we know cause trouble. And then complement levels are decreased because they're being used up in the kidney in these antigen-antibody complexes. Metabolic acidosis, again, that's from the decrease in GFR. And then in urinalysis, we already know these. So proteinuria, hematuria, red blood cell casts are sort of a hallmark for glomerulonephritis. So when you see that in a in a report or in a question, that's glomerulonephritis until proven otherwise. But we don't see evidence of infection. This is where it's don't get confused. Even though strep is involved, strep is not the causative organism here. It's the body's response to it that is causing all the problems. So you don't see signs of infection. You just see, in the urine anyway, you just see the signs of this glomerular membrane irritation. All right. So treatment, glucocorticoids. The problem here is the immune system. This is an autoimmune disorder. So how do we treat it? The same way we treat lots of other autoimmune disorders, steroids. Steroids turn the immune response down and allows those antibody-antigen complexes to clear. And then we treat the other things that are going wrong with the patient. So if they're hypertensive, we treat their hypertension. If they're dehydrated, we treat their dehydration. We may limit their sodium intake so that the kidneys have less to do. The lower the sodium in your diet, the less fluid your kidneys have to get rid of. And then we can also replace the protein that's lost with albumin. All right, so here's sort of that pathway. Strep infection somewhere, usually not the urine, remember, because it's not a common cause of urinary tract infection. We get antibodies form. The antibodies join up with antigens from that strep infection. They get deposited in the glomerulus, and then we get our acute inflammation. So we get capillary permeability with hematuria and proteinuria. The glomerulus swells, so that reduces GFR. And then inflammation also causes cells to duplicate, so that too reduces GFR. So, and then the reduction in GFR creates that renal failure in a few, chronic, and the hypertension as well, elevated blood pressure. So how does this resolve? Most people get better, and they never have another problem. Some people will go full on into acute renal failure and die if they don't get a transplant. And they're not high on the transplant list because these antigen-antibody complexes would just destroy the new kidney too. So you don't want to be here. And then in some people, it can become chronic. It's an autoimmune disease, so the bodies can continue to produce these antibodies. And if it does, you're going to end up in this category where eventually your kidneys are going to shut down, and now you're a chronic renal failure patient. All right. And we won't talk about that. All right. So that's glomerulonephritis. And one of the take-home messages tonight is the difference between a GN, so a glomerulonephritis, because this is a discrimination that comes up on tests sometimes. We call that a GN, and a nephrosis. So now we'll talk a little bit about nephrosis. Same site of problem. You know, where is the site of the problem with glomerulonephritis? It's at that glomerular membrane. There's been a breakdown between that filter between blood and what will become urine. In nephrotic syndrome or nephrosis, very same site of problem. It's that membrane that sits between blood and urine. The difference is, in glomerulonephritis, the membrane is so screwed up that it allows red blood cells and protein through. So here we have RBCs and protein going into the urine. So into the urine. Nephrosis is milder than that. Instead of both, all we have in nephrosis is proteinuria. So it's only protein that's ending up in the urine. Now, as we lose lots of our plasma proteins, that osmotic pressure disappears, and we get that generalized edema. So nephrosis has many of the same symptoms as glomerulonephritis, just without the blood and the urine part. So you still get generalized edema, and it's that edema that becomes the problem. Because as more and more fluid leaves your vessels into your interstitial space, there's less and less circulating blood. So essentially, this can result in shock. You know, you haven't lost any fluid, but it's not in the right place. Instead of being in the vessels, it's everywhere but. So you see this as an idiopathic disorder in kids. You know, they usually present with significant swelling over, several days, and it's nephrotic syndrome. But you can also get this with lupus, as well as certain nephrotoxins. A nephrotoxin is just a chemical or a medication that damages the kidney somehow. So nephrosis is also inflammation of the glomerular membrane. It's just not as bad as nephritis. So what we see is a direct result of this leaking protein into the urine. So hypoalbuminemia, the most common protein in the blood is albumin. So what's going to be lost then? Well, albumin, because it's the most common. When your albumin goes down, your osmotic pressure goes down. That causes generalized edema. That's going to cause your blood pressure to either be low or normal. Low because you have a low plasma volume. Your aldosterone is going to be high because essentially the kidney is trying to hold on to whatever water is left in the body because it's not seeing enough blood flow. And then we see some sort of weird things. We see a high blood cholesterol oftentimes with nephrosis. The reason for that is cholesterol is normally held by albumin. So when your albumin goes down, your cholesterol goes up. And then we'll see sometimes the urine has kind of a milky appearance because lipids start to appear in the urine for that same reason. There's nothing to hold on to it in the blood, so it ends up being filtered in the urine. All right. So signs and symptoms, proteinuria, lipiduria, not red blood cell casts. These are protein casts that we see in the urine, massive edema. And then treatment, again, it's an inflammatory disorder. So what do we throw at inflammatory disorders? Steroids. So glucocorticoids. ACE inhibitors can actually decrease the protein loss in urine. Antihypertensive if they are hypertensive. And then, again, limit sodium. If you limit the sodium intake, that limits the problem of these leaking capillaries. All right, so glomerulonephritis and nephrosis. Both of these are inflammatory disorders, not infectious disorders. And both are reasonably common. You know, in a clinical career, you're going to see patients with both. You're going to see kids with nephrosis. You're going to see adults with nephrosis secondary to something else. You're going to see glomerulonephritis. So one of the reasons they cover those in this chapter is because they're very common. All right, so infection, inflammatory disorders are two, and then the next one is obstructions. Again, which I know most of you have heard about these at least. So kidney stones, also called urolithiasis. So lithos is stone, uro is urine, so urolithiasis. Also called calculi, another name for stone. So stones can develop anywhere in the urinary system. The reason for that is, you know, urine is water with a bunch of stuff dissolved in it. And just like we've all seen in chemistry class, you know, if you mix certain solutions together, stuff comes out of solution and you start to see, you know, rocks or little bits of stuff. That's essentially how a kidney stone forms. It precipitates out of the urine. So we find stones, well, they can be very small or they can be very large. And their size plays a major role in what we expect them to do. So small stones can even pass unnoticed. Large stones are actually not bad to have because they can't get stuck in anything and they tend to just sit there until they're broken up. So the worst ones are the medium-sized ones. Small enough to move through the ureter, but large enough to cause obstruction or significant pain. So we get kidney stones when there's lots of solute in the filtrate. So, you know, a person with, you know, chronic dehydration, they don't drink enough water together with certain things in their diet, like a high amount of calcium in their diet, and you'll end up with precipitation that causes stones. And then urinary tract infection. Bacteria are alive, so they metabolize what's in the urine into various things. So people with urinary tract infections can end up with stones that essentially the bacteria made. You know, they turned what you excreted into some other compound which wouldn't stay in solution and came out. So typically, kidney stones, you only have problems when they obstruct something. So the obstruction can lead to infection. It can lead to a condition called hydronephrosis. This is where essentially urine backs up into the kidney and starts to destroy it with pressure. I think I've got a picture of that, yeah, in a minute. And then obviously pain. You know, you get that colicky pain. So here in this example, we've got giant stones, right? And they have completely blocked this calyx of the kidney. So what we see is the kidney keeps making urine, right? And it's making urine at about blood pressure, you know, so about 120/80. So if that pressure has nowhere to go, essentially it starts to flatten the kidney around it. So this is classic hydronephrosis, where kidney tissue has been sort of squeezed to death by these big spaces of obstruction. So this can cause renal failure. I mean, obviously this kidney is not going to work as well as a kidney that's normal. So if this goes on, this can cause renal failure. All right. So stones can be made of lots of different things. The most common ones are calcium salts. So this is a patient who has a high calcium diet or has some hormone problem with calcitonin or parathyroid hormone where their calcium levels are too high all the time. Or if they have a condition where they have very alkaline urine. Normally our urine is quite acidic, but with certain kinds of diets and medication, you can push the urine into alkalinity, and when that happens, the calcium has a tendency to crystallize out and form stones. Uric acid, this is the same thing that causes gout, and uric acid will precipitate as well and create a stone. So we see this. Uric acid is formed from purines. Purines are one of the nucleotide types. So patients with high nucleotide diets or gout or cancer, chemotherapy, because chemotherapy destroys the whole cell, including the DNA and RNA. So the DNA and RNA end up going and becoming uric acid, which can become then a uric acid stone. This is a problem with acidic urine. So If you make calcium stones, we try to keep your urine acidic. If you make uric acid stones, we try to keep your urine alkaline. So one of the treatments for gout and uric acid stones is a diet that makes the urine alkaline instead of acidic like it usually is. And then these are less common, struvite and cystine stones. The thing with these is they don't show up on X-ray, but they do show up on CT scan. So not all stones can be seen on a simple X-ray. Some kidney stones you have to get a CT scan to see. All right. So stones in the kidney or the bladder are often asymptomatic because they're not on the move. You know, they're just hanging out there, and until they obstruct something, they're not going to cause any symptoms. When they do start to move, that's where you get the classic, kidney stone presentation, and that's renal colic. So colic is pain that comes and goes, and people say that the renal colic with a kidney stone is one of the most intense pains that people experience. People have likened it, even women who have had babies have likened it to worse than childbirth. So you get these intense spasms. A lot of times it's not just the pain, but these patients really appear sick. They're nauseous, they're vomiting, they look shocky, cool, moist skin, rapid pulse. People complaining of flank pain and look just terrible, probably have a kidney stone. Anybody in here have a kidney stone in the past? No, none. Usually they're very common, so you'll encounter people who've had them. All right. So ultimately, we try to pick these up on X-ray or CT scan. That shows us the stone, and now we know what we're dealing with. So in terms of treatment, small stones, the treatment is hydration, pain management, do nothing else. So the stone will eventually pass. It's going to make its way to the bladder. It's going to make its way out. Oftentimes we'll have patients filter their urine, so that we can try to pick up the stone. And then analyze it so we can tell which kind of stone it is so we know how to treat subsequent stones. There's some new fancy therapies. ESWL, this is where they take sound waves and basically shatter large stones into smaller pieces so that they're easier to pass. You can do that same thing with a laser. You can try to use medications to dissolve stones that are already present. This doesn't work very well, though. The best treatment for kidney stones is prevention, because once you have them, they're very difficult to dissolve. If it's huge and it's blocking the kidney, like our hydronephrosis kidney a minute ago, they'll go in there and take it out surgically. So in terms of prevention, consistent good hydration, that's the single biggest thing. It is never a bad idea to drink, to drink plenty of water. It's good for your cardiovascular system, it's good for your urinary system and your GI tract. So drink plenty of water. If you do make stones for other reasons, then manage the urine pH with, again, medications or diet. And then if it's an underlying condition, in other words, you got a kidney stone because you're on a diuretic for hypertension, let's say, then you try to treat that underlying causative condition. All right. So hydronephrosis, we already saw. It's a secondary problem. Hydronephrosis never occurs all by itself. It only occurs when there's a blockage of some kind. So either from a calculi, a tumor, prostatic enlargement untreated can do this. Essentially, the urine backs up into the bladder. When the bladder's full, it backs up into the kidney and starts squeezing that parts of the kidney to death. Often it's asymptomatic in early stages, so you have to go looking for it. And again, in children who have that GU reflux, where the valves don't work, this is another thing they look for because that can lead to hydronephrosis as well. All right. Because if you do nothing about hydronephrosis, you're going to get into chronic renal failure. If you don't have enough functioning kidney, well, you're going to be in renal failure before too long. All right. So that's obstructive disorders. There's a couple of vascular disorders. Nephrosclerosis is essentially arteriosclerosis, which we talked about in our cardiovascular system, that's affecting the kidney. So just like everything else in the body, the kidney has arteries and the kidney has veins. Well, as you get older, those arteries tend to get thicker and harder. And not just the large arteries, but the small ones and the arterioles too. Arterioles are critical to how the nephron functions. Arterioles control the glomerulus. So when the arterioles start to harden, you're going to end up with a decrease in blood supply to the kidney. That's going to trigger stimulation of renin, so your blood pressure is going to go up. And if it gets bad enough, just like any other tissue in the body, ischemia will kill parts of the kidney. So nephrosclerosis is one of the causes of chronic renal failure. Only instead of being a kidney problem, it's really a vessel problem. But the kidneys don't work without vessels that work correctly. So let's see. We're going to skip that part. Okay. So the treatment for nephrosclerosis is to try to keep the blood flowing to the kidney. So diuretics, antihypertensives, beta blockers, and then limit sodium. One of the reasons that we limit patient sodium in kidney diseases is because the less sodium you take in, the less water you take in, and the less work the kidney has to do. So one of the tricks is to keep patients on a low sodium diet. All right. So vascular disorders, a few congenital disorders. So things can go wrong with the development of the kidney. This one we already talked about, GU or VU, vesicouteral reflux. This is where urine goes from the bladder back towards the kidneys. Not supposed to do that. There's supposed to be a valve there to prevent that. So in patients with this disorder, we look for urinary tract infections and we try to prevent them, because a urinary tract infection in somebody with VU reflux is much more likely to become a pyelonephritis, and pyelonephritis leads to scarring. So that's one. Agenesis, sometimes people are just born with one kidney. One kidney just didn't form. Hypoplasia, this is kidneys, or one or both kidneys are too small. In an ectopic kidney, the kidney is in a different place. The kidneys kind of move around a little in the early development of the human being. So this can be an abdominal kidney, one that's in the peritoneal cavity. It can be one that's up too high. Basically, it just means that they're not in their normal place. In some people, the two kidneys join together, and they form this kind of horseshoe at the back around the spine, so we call that a horseshoe kidney. All right. Polycystic kidney, adult polycystic kidney disease. This one's kind of unusual. It's a genetic disorder, autosomal dominant, so you only need one bad gene to get it. But it doesn't have any symptoms until you get to be around age 40. And then at around age 40, your kidney starts to look like this. So, kidneys are supposed to be sort of nice and uniform in appearance. And what happens in these is each one of these little cysts was a nephron that essentially couldn't empty and just kept filling up and filling up and filling up. So, you can imagine that this kidney maybe wouldn't work very well. So adult polycystic kidney disease is one of the causes for chronic renal failure. So we get enlargement of the kidneys, destruction of kidney tissue. The diagnosis is usually by CT or MRI, and nowadays ultrasound is also used to diagnose adult polycystic kidney disease. But it is genetic and it is autosomal dominant, so it certainly runs in families. And because it doesn't present until quite late in life, you can imagine that most people by the time they're age 40 have already had their kids, right? So they find out at 40 that their kids will very likely have this same disorder. So one of the reasons it stays in the gene pool, so to speak, is because it's such a late, its presentation is so late. All right. A cancer, Wilms tumor, its claim to fame is it's the most common tumor in children, and it's one of the relatively unusual congenital tumors. In other words, children are often born with Wilms tumors. So typically we think of cancer as a disease of people as they get older, but this is an exception to that. Now, it's usually unilateral. It's usually encapsulated, which means that its prognosis is very good. You take out the affected kidney, usually you get the tumor with it, and then that's a cure. There may be metastases, but metastases are not common in Wilms tumor. And here again, one of the causes of a Wilms tumor is a genetic disorder. So it's a problem with the tumor suppression gene, or a tumor suppressor gene.
Isn't Wilms tumor the one where you get hit in that spot, like in a fight, and it bursts off the nose and spreads really fast?
I haven't heard that before, but that could be. I just don't know that. They can go undiagnosed.
Yeah.
Yeah, I think you're right about that, because it's encapsulated. That's how it develops. But if you were to break that capsule open, it's a cancer. So yeah, you could set it loose, so to speak. All right, another question. All right, polycystic kidney disease. What's true about it? There's also a pediatric polycystic kidney disease, but your book didn't talk about it, so we won't either. It presents much earlier and much more severely.
I don't have the question.
You don't? Just wait for the next one, because I can't send it again without shutting everybody's answers off.
Mine came in from last time.
You got the first one, but not this one. That's weird. This system, I'm not pleased with it. But I've been outranked on that one. All right. Correct answer here is D. Polycystic kidney disease is genetic. It's autosomal dominant. So, you have like 50% of a chance of giving it to an offspring. All right. The pathophysiologic basis of acute glomerulonephritis is which of those things?
It says in the book for polycystic in children that it's a recessive gene.
Yeah, I think you're right about that. I think that's true. But it's more severe.
Yeah. They're either stillborn or dies during the first few months.
Yeah. And they're not related. That's the other thing I remember about it. In other words, the gene for the adult version has nothing to do with the gene for the recessive pediatric version. Even though you'd think they would, but they don't. All right, so we got a split here between B and D. So remember, glomerulonephritis is not an infection. It's a response to an infection, an inappropriate response. So the answer here is D. It's the immune complexes that resulted from an infection somewhere else that get laid down in the glomerulus and screw up the glomerular membrane. Okay. So in our last 5 minutes, just briefly, renal failure. So not surprisingly, renal failure, all that means is that the kidneys are no longer performing their normal functions. So what are the kidneys' normal functions? Get rid of waste products, manage fluid, in other words, get rid of excess fluid or hold on to fluid when we're in fluid deficit. Control blood pressure, so that's done through the renin-angiotensin-aldosterone system. Manage electrolytes, so potassium, calcium, magnesium, those guys. And control red blood cell production. So the symptoms that we see in renal failure are all related to a deficit in one of those primary functions of the kidney. So the two big categories, acute renal failure is something that happens very quickly, like over weeks. Chronic renal failure is something that happens very slowly, over months to years. So to get an acute renal failure, you have to have acute bilateral kidney disease. Now, it doesn't necessarily mean that your kidneys caused it. So, for example, circulatory shock that's prolonged. You've got a patient who's septic and you've had trouble keeping their blood pressure up for the last week. Their kidneys can die from ischemia for that. They don't have enough blood flow. Not enough blood flow is not enough oxygen. The kidneys die off and you get into acute renal failure. There are certain drugs and chemicals that in high enough amounts will destroy the nephrons, so destroy the kidneys. Mechanical obstruction can do this, although it's pretty uncommon. You'd have to have massive stones or blood clots that were blocking the urine flow beyond the kidneys. So you get a nephrosis as a cause of acute renal failure. So the, all right, we're about out of time, so I'm going to just skip ahead. In chronic renal failure, same thing, same endpoint. Dead kidneys, kidneys not filtering, not getting rid of waste products, not controlling blood pressure, not controlling fluid. You just get there slower. So you can get these from a number of different diseases, from diabetes, lupus, polycystic kidney disease, lots of causes for renal failure. But and it goes in stages. So in chronic renal failure, first you lose your renal reserve. In other words, the extra that you have. You know, we have 2 kidneys, we only really need 1. So that shows you that we have extra, kidney. But when you've used up that reserve, in other words, when all your extra nephrons have died, you start getting into renal insufficiency. So we have a decrease in GFR, which leads to waste retention. And in this phase, the kidney, you'd think that a failing kidney would produce less urine, but in this middle phase of both acute and chronic renal failure, the kidneys actually produce too much urine. So when the kidney gets sick, one of the things that it loses the ability to do is recover water from the urine. So between the onset and the final failure, you have this phase where you're polyuric, in other words, where you produce lots of urine. But it's very dilute, so it doesn't have many waste products in it. Decreased erythropoietin secretion and increased blood pressure. And then when you get to the end stage, this is where the kidney is just not working. In that middle stage, it's working, but it's not working well. So you get a very low GFR, not enough GFR to manage electrolytes, wastes, or fluids. So you get azotemia. This is high urea, blood urea. Anemia and acidosis are the 3 A's of end-stage renal failure. Significant oliguria or even anuria, where you just don't make urine. So in the patient with full-on renal failure, they just don't make urine. So that's one of the signs that a patient needs dialysis, is when you see no urine, you're not getting rid of any waste products. So you're going to have to do that extrinsically instead. All right. And we'll stop there for today. Well, have a good Halloween, everybody.